Uh, Hello, everybody. Today we have our first webinar under the new brand. It's a Polish Pharmacy Practice Research Network. is a new organization which is mainly focused to develop the practice research in Poland, and also to show as much as evidence as possible that pharmacists can do a lot of good things for the healthcare. And our today guest is Heather Naylor. She's a clinical pharmacist, and she's going to talk about basically different adjustment of different medicines regarding obviously problems with kidneys, acute kidney injury, these kind of things. So hello, Heather. Thank you very much for accepting our invitation. Can you just please tell us a few things about yourself?
Oh, sure. Yes. Thank you so much for having me today. It's a pleasure to speak with your group. So as he introduced me, my name is Heather. I'm a pharmacist in St. John, New Brunswick. So I've been in practice for about 12 years now, and I've worked in dialysis and kidney transplant for 10 of those 12 years. So I have a lot of experience with renal drug dosing and working with people with chronic kidney disease and on hemodialysis.
This is excellent. We have a lot of problems in Poland because people are taking too many medicines. Most of the time, basically, the kidney failures are caused by taking too many, for instance, NSAIDs and mixing them with different medicines. We don't have particular skills in Poland, basically, to how to adjust this form for medicines, etc. So I'm hoping that you will find it very, very useful. So we have a presentation for you today, but before that, I would like to just say thank you very much to DOTYCZOCE, who helped us to organize this meeting today. Also to Regis Weilancourt, my mentor, who is also supporting developing of Polish pharmacy practice here in Poland. Thank you very much. So we can start now.
Great, thank you. So yes, today we'll go through some practical tips for renal drug dosing. So I'm hoping that this is informative for your practice and gives you a place to start. At any time, I guess if you have questions, I think there's a chat box, and at the end we'll have a time for questions and answers as well. So today I want to go through first the origins and limitations of serum creatinine and the different equations that we have available to estimate renal function. So after we go through a bit of the theory and the history, we'll discuss when to use creatinine clearance versus eGFR for renal drug dosing. And then we'll go through an approach that you can use to work up your patients when you're looking at dose adjusting their medications for renal impairment, and go through a few cases so that you can apply your knowledge. All right, so we'll come back to this patient case at the end of the presentation, but for now, I want you to think about if you encountered this person in practice, what your current strategy might be for approaching this. So Mrs. S is a 65-year-old female kidney transplant patient. She's 64 kilograms and 5'2". That's about 157 centimeters. So she received her kidney transplant in May of 2021. And at the time of the transplant, she was at intermediate risk for CMV, so cytomegalovirus, which is something that transplant patients are at risk of. So she was intermediate risk because the kidney she received was negative for CMV, but she had had CMV in the past and was positive. So she's on valganciclovir for 3 months to suppress any viral load and prevent any infection. This medication is renally drug adjusted or dose adjusted. So right now she's currently on 450 milligrams every 2 days. But you've noticed as you follow her blood work a few weeks out post-transplant that the serum creatinine is coming down. So it was 189 on June the 16th, and on June 25th, it was 132. So you're wondering if maybe we need to increase the valganciclovir dose now that her renal function is improving. So just give some thought if you saw this patient in practice. How would you determine their renal function? Where would you go to look for dose adjustments of the medication? And we'll come back to this at the end of the case. So there's a lot of different renal function equations out there that you can use. So I'm not sure what you guys currently use in Poland. Here in Canada, we use a mix of the Crcl and the CKD epi is what our lab uses to report kidney function. So within Crcl, there's various formulas you can use. So you can use it for a normalized body weight of 72 kilograms. You can use it with adjusted body weight if patients are overweight, ideal body weight if they're a lower weight patient. And the Salazar-Corcoran equation is used for obese patients. So lots of different options. It's oftentimes difficult to decide, what is the best one to use. But I know here in Canada, we often get caught up with, what is the right one? And I've seen colleagues get into disagreements over whether you can use Egfr for renal dose adjustments versus Crcl. And I think sometimes we miss the bigger picture that all of these equations at best are just an estimate of a patient's renal function. So they're not any one 100% accurate. And at best, we're taking a snapshot of what their approximate function is. So it's okay to understand it's not 100% precise and do the best you can with the data that you have. And often there's more than one right answer. So you could take either path and still have a correct dosage adjustment. Where I work in nephrology, we often say it's very gray oftentimes because we don't have the big studies that cardiology has with a lot of patients and really good evidence. So oftentimes we're trying to take what we do have, even if it's smaller sets of data, and make out the best that we can. And oftentimes, you could do one thing one way and somebody else would do it another way, and they're both correct options. So I use this slide here to demonstrate when you're looking at renal function, you can use the same equation for different patients, and their characteristics will affect what result that you get. So for patients that, like this middle guy who is a 58-year-old white man who's 68 kilograms, patients that are more close to that, what we call normal weight, around that 72 kilogram mark. So they're not obese, they're not underweight. You can really use any equation for that population as long as they're not very elderly, and you're going to get approximately the same answer. So you can see with him, all these patients have a serum creatinine of 120, and with the 68 kilogram male, no matter what formula of the Crcl you use to get creatinine clearance, or even using the CKD epi for Egfr, the numbers are very close. So the difference between 54 mils per minute and 59 mils per minute, you would probably get the same dose recommendation for either of those. So for those patients, you can really use any equation and it's okay. It's when you get into patients that are maybe overweight. So this patient, again, is 120 kilograms. But when you work out their BMI, they'd be considered overweight or over their ideal body weight. So you can see here when you use the CKD epi, it really underestimates their kidney function compared to creatinine clearance with their actual body weight. And depending on the drug and the cutoff points for dose adjustment, you may actually give too little drug for that person. And then for the elderly patients that we worry about, because they tend to be more susceptible to adverse effects and drug toxicity, and this little 45 kilogram lady that's 80 years old, if we use the Egfr for her, it's saying her clearance is 37 mils per minute, but using her ideal body weight, which is probably what you should use for her with Crcl, it's 23 mils per minute. And a lot of drugs, the cutoff point for dose adjustment is 30 mils per minute. So if you were using Egfr for her, there's a good chance that you could give her too much drug, which could have consequences. So just keep that in mind. If somebody's normal weight, probably doesn't matter as much what equation you use to estimate renal function, but it's when you get into elderly patients, underweight patients, or obese patients, you need to be a little bit more careful. So I know this slide is very busy. I just put it on here to give you an idea of the history and the timeline behind some of these equations. So back in 1976 was when Crcl was developed to calculate creatinine clearance. And that was really all we had for almost a 20-year period before the MDRD equation came onto the scene. And that was the first equation that was used to estimate your Egfr, so your estimated glomerular filtration rate. So that one was considered best practice for a number of years until 2009. And that's when the CKD-EPI equation was created. So CKD-EPI is now worldwide considered the gold standard for estimating a patient's renal function. But it wasn't necessarily used to do a lot of the pharmacokinetic studies where we estimated renal function and figured out dose adjustments. So a lot of those studies were done back in the 70s, 80s, 90s with Cockcroft-Gault. So Cockcroft-Gault, like I said, was developed in 1976. And when they derived this equation, they took 24-hour creatinine clearance measurements from 249 men, and their average weight was 72 kilograms. So it's usually used using total body weight, but you can use it with ideal or lean body weight in patients who are obese or volume overloaded. And I've just put this here as a reference if you want any of the equations, but I'll show you later. There's lots of formulas out there in electronic calculators now, so you don't really have to do these by hand anymore. So, and just a note about Cockcroft-Gault and serum creatinine, back when we were using Cockcroft-Gault to calculate clearance, especially for pharmacokinetic studies, prior to 2009, creatinine wasn't standardized between labs. After 2009, we started using this isotope dilution mass spectrometry that was used to standardize creatinine measurements among labs worldwide. But because before 2009, a lot of these kinetic studies, we used the non-standardized version, recommended drug doses that came out of these kinetic studies are probably lower than they would be today. Clinically, this doesn't really change our approach, but just something to be aware of. And CKD-EPI, like I said, was developed in 2009 and is now the gold standard for measuring renal function. So I know in Canada in the last 5 years, all of our labs have switched to reporting eGFR in a patient's lab report, and they'll use this to give an indication of the renal function. Probably 6-7 years ago, we just had serum creatinine reported and you had to calculate the clearance yourself. But now when a physician or an allied healthcare worker looks at a patient's blood work, you'll see creatinine and then eGFR listed below there. So in this one, the main benefit versus MDRD is that for clearances of 60 mils per minute or higher, this one has been found to be more accurate. MDRD that was used from 1999 to about 2009. It was good for estimating function if your clearance was less than 60 mils per minute, but anything above 60, it tended to overestimate. So, and this is just a table comparing the different formulas to have on hand. So Cockcroft-Gault, MDRD, which we don't really use anymore, and CKD-EPI. So Cockcroft-Gault versus eGFR for renal drug dosing. I know in Canada and the United States for a while there was a lot of controversy over whether you could use eGFR for estimating patients' renal function when adjusting medication. And this really came into play more in the last 5 years because physicians now had access to the eGFR. Before they'd have to call pharmacy and say, you know, what's this person's creatinine clearance? Can you calculate it for me? But now when they look at the patient's blood work, we have the eGFR reported so they can dose adjust medications based on that. And for most patients, it's okay to use eGFR in place of Cockcroft-Gault. But for patients, like we said earlier, if they're really underweight or elderly or perhaps obese, they really should be using Cockcroft-Gault instead of eGFR. Having said that, if you don't have access to anything else, an estimate is better than no estimate at all. So just use eGFR very cautiously in those outlying populations. And keep in mind that most kinetic studies were done with Cockcroft-Gault instead of eGFR. Some of the newer medications you will see in the product monograph, they are actually reporting those dose adjustments in eGFR. So things like dapagliflozin and empagliflozin, the new SGLT2 inhibitors, you'll see in that monograph, they've actually used eGFR. So, and this is a nice table to refer to if you're not sure which one to use. So if they're non-obese and under 75 years old, you can use either the Crcl or the CKD epi. If it's an obese patient, it's recommended to use either Crcl adjusted or the Salazar-Corcoran equation. So if you just type that into Google, you should come up with a link that can help you plug in numbers to calculate that. And you can also use the global RPH website for creatinine clearance, and it will give you almost all of these formulas when you plug in your data. And I'll show you that a little bit later in the presentation. For the elderly, they usually recommend Crcl with ideal body weight because that gives you a more conservative estimate in that population. And they're the ones that we worry more about giving too much drug, just where they're more susceptible to toxicity and adverse effects. So the very elderly, this is often the one that I will use. And obese elderly, you can use the Crcl adjusted or the Salazar-Corcoran. So, and if you want to look at some electronic resources, the National Kidney Foundation has a GFR calculator that you can get as an app for your phone, or the Global RPH Creatinine Clearance. So that one, I'll usually just go into Google and type in Global RPH Creatinine Clearance, and it brings you up to the website. So then you just plug in your patient's age, height and weight, and creatinine, and it will show you what the creatinine clearance is with all of those available formulas. There's also QX Calculate, that's an app you can get for Android and iPhones, and I believe MD Calc also has an app as well. So just a quick note about drug dosing in acute kidney injury, which you may come across if you do work in the hospital, especially in the ICU or on an internal medicine floor. If you have a patient that comes in an acute kidney injury, it's a bit trickier to calculate their clearance and establish the proper dose. So for those patients, Crcl is really not as accurate. So that one, because it was calculated in patients who had stable renal function, it doesn't really apply to patients that have fluctuating creatinine. You can use it as an estimate, but keep in mind it's more difficult to dose adjust for these patients. So usually what I would do is check multiple sources for dose adjustment recommendations, depending on the medication, and look at the trend in their serum creatinine. So if it's steadily been increasing and it's still going up, then I might decide to cut back. Versus if it's gone up a little bit and staying steady, you might be able to get away with a higher dose. So look at their creatinine, their urine output, how sick they are, and what the indication is for the drug before you make your decision. And with these patients too, sometimes the volume of distribution is quite affected when they're in acute kidney injury. So you'll often see, for instance, patients in ICU who are getting antibiotics, they'll actually recommend to give a loading dose for a couple of days to get those antibiotic levels up to adequate concentrations, and then you can cut back on the dose if you need to. So, and with creatinine, it's important to remember the creatinine value you see that's reported with the patient's labs, that's reflecting their kidney function from probably like 48 to 36 hours prior to when that lab value was taken. So it's a delayed response between decreased kidney function and increased creatinine. So just look at the trends, look at the drug characteristics, and dose adjust as best as you can. So I'm thinking about, what's the harm if my patient receives extra drug versus the harm if they're underdosed. So if someone's getting amoxicillin, that drug, chances are if they get extra, it's not going to cause a lot of harm. But if you don't get them enough, we may not treat their infection adequately and start to breed some resistant bacteria. Versus if you're looking at another antibiotic like gentamicin that has a really narrow therapeutic index, we don't want to give patients too much of that drug because of the ototoxicity and other toxicities it can cause. So you'd want to be more cautious with something like that. And just a note about drug dosing and dialysis. I know this is something, if you don't work in this area, you may not come across these patients as much, but if you do see them in your practice, patients on dialysis, we don't use Crcl or Egfr to do their dose adjustments for medications. So there would just be a standard dose of what to give if your patient's on hemodialysis or peritoneal dialysis. And things to keep in mind with these patients is that, especially for hemodialysis, the characteristics of the drug really affect the dosing and how much is removed. So if it's primarily renally cleared, you're going to want to dose reduce. And then depending on the characteristics of the drug, so drugs that are smaller in size, don't bind to a lot of protein, have a smaller volume of distribution, and those drugs are more likely to be removed by hemodialysis through the dialyzer versus larger molecules or something that's bound to a lot of protein. You're probably not going to pull it out of the blood as easily. Or if it distributes to a lot of the fat cells and fat tissue, it's going to be harder to remove. But for the drugs that are readily removed, you'll often have to give a top-up dose after dialysis. So don't calculate creatinine clearance or Egfr for these patients. Look at different references specifically for hemodialysis or peritoneal dialysis. So I usually check to see what percentage of the drug is removed by dialysis and look to see whether they recommend a top-up dose. If a lot of the drug is removed by dialysis, we try to give the medication after dialysis to minimize how much is removed. And it's always a good idea to check more than one reference if you can. So these are some of the ones that I like to use both for dialysis drug dosing as well as renal drug dosing. So LexiComp and Micromedics, we have access to these through our hospital resources here. There's also an app you can get called the Dialysis of Drugs, but you do have to pay for a yearly subscription. And then this Dialyze IHD website was put together by a group of pharmacists from British Columbia. So that one's specifically for intermittent hemodialysis dosing. There's lots of evidence-based resources on there, and it will tell you what dose of the drug to give if they're on dialysis and whether or not you have to give a top-up. All right, so that was sort of the theory and background piece of things. So now we're going to get into more of the practical stuff, and we're going to go through this easy approach to renal drug dosing. So this was developed by a colleague in Victoria, BC, Dan Martinussen, who's also a renal pharmacist. So we'll use this acronym to guide you through how you can approach renal dose adjustments in your patients. So EASY stands for estimating renal function, assessing the drug properties, sickness acuity assessment, and whether or not to say yes to dose adjustment. So when you're estimating renal function, this is where you'll look at the patient characteristics, figure out their clearance, and then check your resources to see if there's renal dose adjustments recommended. So you can use the Egfr at a first glance to get just a snapshot of what the patient's renal function is. And then depending on the patient characteristics, you'll probably want to go and calculate creatinine clearance to compare and see if there's a large difference there. So you can use that global RPH calculator if you like, or whatever app you have on your phone to see what their creatinine clearance is. And then once you have that snapshot of what the renal function is, then you would go to either the product monograph, Micromedics, LexiComp, to look up and see if you have to dose adjust the medication for renal function. For some drugs, if there's not a lot of info, you could go back to some of the original research papers, but I can't say I've really had to do that for most drugs. Usually I just go to LexiComp or Micromedics and go to the renal dose adjustment spot or kidney dose adjustment, and it will show you where they recommend what cutoff. So oftentimes medications, it will be if the creatinine clearance is less than 60 mils per minute or less than 30 mils per minute are really common cutoffs for dose adjustments. But it's different for each drug, so it's always good to check individually. And with newer medications, I would also check to see in the kidney dose adjustment part if they used EGFR or creatinine clearance for their cutoffs. So if they use EGFR, like the SLG2 inhibitors, then I would use EGFR to estimate the renal function. But if it's an older drug, then you could use creatinine clearance or the EGFR. And some patient factors to consider besides obesity and age would be if they've had an amputation, any muscle wasting. Sometimes if they're on certain medications that help secrete creatinine, they might have falsely elevated renal function. And if they're vegan or vegetarian, they may have slightly lower creatinine just because they're not eating as much meat. So once you have their estimated creatinine clearance or EGFR, then you'll look to see the drug itself, if there's characteristics that you should consider when looking whether or not you should dose adjust the medication. So it's always good to look and see what percentage of the drug is excreted renally versus through the liver. And if it is primarily renal excretion, does it have active metabolites or toxic metabolites for some drugs? So if the drug's renally excreted, but it's excreted as a non-active metabolite, we're not as worried about it building up and causing harm. But it's those drugs that have active metabolites that if they could build up in chronic kidney disease, you might want to dose adjust. Also look at the therapeutic window. So like I said, with things like amoxicillin that have a very large window, and you're probably not going to cause harm by giving a little bit extra. In contrast, things like gabapentin that might be quite sedating, or some antibiotics like gentamicin or vancomycin, you really don't want to give too much drug. So for those drugs, you'd want to be a little bit more cautious when you're adjusting. Also, any drug interactions that might affect your drug level, and if the clearance is altered by other disease states like liver failure, CHF, those type of things. So at this point, you've looked at the patient's renal function and estimated that. You looked at the drug to see, if we're more worried about possible adverse effects from having the drug build up, or if it's, a higher threshold where we don't worry quite so much. So once you've done that, then you want to look at your patient and see how sick they are. So if the patient, is really sick, maybe they're septic, and you're giving them antibiotics, you're going to be probably more aggressive with them, especially in the beginning, to make sure that we're not under-treating them. Versus if it's somebody coming in to a walk-in clinic as an outpatient and they're quite healthy, or maybe you're starting them on a medication for pain and you're able to start at a lower dose and titrate up slowly. Those are the things that you want to be thinking about, and the consequences of what's going to happen if I don't give enough drug to this patient at this time versus what if I give them too much, and what are the consequences of that. So weighing your risk versus benefit and using your clinical judgment to assess how sick the patient is. So once you've done all that, then you can decide whether you want to dose adjust or not. So, and if you have decided to dose adjust, then look at those references to see if you're decreasing the total dose or the frequency. And then consider if you need to monitor after that, document your dosage adjustment if you can. And if it's a hospitalized patient, thinking about monitoring and the patient dynamics. So if there's somebody who's acutely ill in hospital and you're giving them antibiotics for sepsis, coming up with a monitoring plan. And what's going to happen if their kidney function starts to improve, knowing where the cutoff is to increase that dose, or vice versa, if their kidney function's declining, knowing when you might want to step in and reduce the dose of the antibiotic. All right. So that's an approach that you can follow. So we'll apply that to a couple of cases, and hopefully this will all start to come together for you. So the first case is that you're a hospital pharmacist working an evening shift in the dispensary. You come across an order for piperacillin tazobactam for a patient. So JD, who's a 62-year-old male, and he's admitted to hospital with hospital-acquired pneumonia. So he's been started on pip/tazo 4.5 grams, IV Q6H. His serum creatinine that was drawn that evening came back at 185. So when you look at your pharmacy software program, it's saying his creatinine clearance is 37 mils per minute. So what would you do? So if I was screening the order, I'm just thinking the approach in my head would be, okay, 37 mils per minute seems a little low. So I'm going to look up the pip/tazo dosing to see if the 4.5 Q6 is an appropriate dose, or should that be dose reduced? And then I'm probably going to go back and look at the trend of his creatinine to see if this is where he normally runs. And then maybe plug his patient information into that global RPH calculator to get a better sense of the range of what his clearance might be, and then go from there. So a bit more information about the patient. He's otherwise fairly healthy. He has some gout and hypertension, dyslipidemia, and some arthritis. So not on a lot of home medications, just some hydrochlorothiazide and perindopril for his blood pressure, atorvastatin for cholesterol, and ibuprofen when needed for some arthritis. So he weighs 79 kilograms. In hospital today, his temperature is elevated at 39.5 degrees Celsius. Heart rate's running a little bit higher at 94 beats per minute, and blood pressure 110/65. His white count is elevated at 24.3, and the chest x-ray is showing consolidation in the right lower lobe, which is consistent with that hospital pneumonia picture. So serum creatinine is 185, but when you look back 2 months ago, his baseline seemed to run around 123. So he is elevated a little bit today. So right now, his eGFR, based on that creatinine of 185, is around 32 mils per minute. So when we estimate his renal function, so calculating that creatinine clearance with total body weight, ideal body weight, and actual or adjusted body weight, and normalized, you can see there's a range. So anywhere from 32 to 40 mils per minute, depending on which equation you use. His baseline creatinine clearance, if we look at that 120 value that was taken a few months ago, he normally runs 56 to 60 mils per minute. So we are seeing some acute kidney injury in the setting of hospital-acquired pneumonia. So looking at the drug properties for pip/tazo and whether it's nephrotoxic, are there other alternatives? Pip/tazo, this probably is a good choice for empiric therapy of the hospital-acquired pneumonia. It does have a more wide distribution throughout the body, but on its own, it doesn't appear to be nephrotoxic. Sometimes when it's given with vancomycin, you can see an increase in acute kidney injury, but on its own, there's no case reports of nephrotoxicity. As far as excretion, the piperacillin portion of the drug, it's 68% renally excreted as unchanged drug, and 80% of the tazobactam as unchanged drug. As far as how sick your patient is, he does have a fever and does have an elevated white blood count. And we've seen on the chest x-ray, it does look like pneumonia, but hemodynamically, the patient is stable. They're on the medicine ward. They haven't required oxygen or intubation. So even though they're sick enough to be in hospital, they're not drastically unwell where they would need ICU care at this time. So if you look in the literature for the dose adjustment suggestions, if you have a creatinine clearance of 20 to 40 mils per minute, it's recommended to give only 2.25 grams every 6 hours of pip/tazo, or 3.375 grams every 6 hours for nosocomial pneumonia. So based on that, the 4.5 grams every 6 hours this patient was ordered is probably a little bit too much for them. So I would probably recommend decreasing the dose to 3.375 grams IV every 6 hours. Some other things you could recommend: the ibuprofen he was taking at home. Now that he's having some acute kidney injury, I'd recommend they hold that and treat pain with acetaminophen if needed. His perindopril, they could consider holding where he's in an acute kidney injury, because sometimes that can make it worse, but restart once he recovers back to his baseline. Hydrochlorothiazide I would keep on for now. The monograph will say, it might not work at a clearance of less than 30 mils per minute, but I know one of our nephrologists here feels that you'll still get benefit up until the point they're on dialysis through some vasodilatory effects. So I wouldn't change that one at this time. But this patient probably should have the pip/tazo reduced. And if his renal function improved back to baseline and he was in that 40 to 50 range, then you could bump it back up to 4.5 grams every 6 hours. So back to Mrs. S, who was our 65-year-old transplant patient. So we're looking to see whether we need to dose adjust her valganciclovir for CMV prophylaxis. And in real life, where I work in the transplant clinic, we do follow this very closely because we've had cases where the patient's kidney function got better, but we didn't catch it, didn't increase their valganciclovir dose. And we've had patients who actually developed CMV infections because we weren't adequately suppressing the virus. And CMV left untreated can be quite detrimental and sometimes even result in death. So it's not something you want to take lightly. So for this patient where her creatinine is dropping, and this is a screenshot of the global RPH tool that you can get online. So I've just entered her data here with her age and serum creatinine, height, and weight. So if you plug all of that in, it will plug out all of these Cockcroft-Gault equations as well as MDRD. And then there'll be this little flashing circle, where it's a screenshot, you can't see the flashing, but it's usually flashing yellow, where it will tell you which one it recommends you use. So I'll sometimes use that, or I'll just kind of eyeball what it's giving me with the different equations to see what their clearance range might range from. So for her, it's anywhere from 27.3 to 44.8, which is quite a broad range of possible creatinine clearance. But the one that the tool is suggesting we use is Cockcroft-Gault with adjusted body weight, and that gives us a clearance of around 33 mils per minute. So then if you look at the prophylaxis dosing for valganciclovir, if she's around 33 mils per minute, she would be in this line here, which is still 450 milligrams every 2 days. So for Mrs. S right now, we don't need to increase her valganciclovir. But if her creatinine keeps coming down and her clearance goes up into this 40 to 59 mils per minute range, then I would recommend to increase the dose of the valganciclovir up to 450 milligrams once a day. Oh, and I should say for that one, I don't know if you're familiar with valganciclovir, but if you give too much of the drug, especially in new transplant patients that are on other drugs that can also lower your white blood cell count, if we give too much valganciclovir, you would risk causing leukopenia. So we don't want to overdose her, but we don't want to underdose either and risk a CMV infection. So it's a lot of weighing those risks and benefits with the drug. So, and the last case I have for you is MC, who's a 54-year-old female, 80 kilograms, and she has stage 4 chronic kidney disease, secondary to diabetes. So today she's in the emergency room with shingles, and the physician would like to prescribe acyclovir for her. So there is a risk of acute kidney injury with acyclovir. So usually through forming crystals or causing acute tubular necrosis. It's more common with the IV formulation. With oral, we don't see it as much, but it is a possibility. So for this one, you want to make sure that you choose the most appropriate renal dose so that we don't increase her risk of acute kidney injury. So this is her blood work over the last couple years. This column here is the most recent. So you can see her creatinine's been quite stable. She tends to be in the range of 230 to 240. and her EGFR has been very stable between 20 and 22. So for acyclovir, I think this dosing table was taken from Micromedics. So if you're between 10 to 25 mils per minute, they do recommend to decrease to 800 milligrams every 8 hours. And that's where this patient would fall. So where she has chronic kidney disease and she's consistently been 20 to 22, she falls very nicely within that line there. So I would dose reduce to 800 milligrams every 8 hours for her. So some last tips to leave you with to hopefully take or drive this all home. If you're looking at drug monographs, they usually specify what equation type they use to determine the dosage and renal dose adjustments for the drug. So it would either be creatinine clearance or EGFR, but always when you're checking dose adjustments, take a look to see what they used. And a lot of newer drugs, like I said, they have started to use EGFR for dose adjustments. So keep that in mind when you're going to figure out what you want to give. If you're in doubt of what to use, I would just go to that global RPH site and calculate essentially a functional range of possible creatinine clearance. Look at that range and look at the drug to see what the risks and benefits are of overdosing versus underdosing, and use that to help you decide what dose to recommend. And I'd encourage you, I find sometimes as pharmacists, we get very caught up in the black and white. So if the cutoff point is 30 mils per minute or less and the patient's at 29 mils per minute, but the doctor wants to give amoxicillin 500 milligrams 3 times a day instead of twice a day, I might not fight that necessarily if they're ordering it 3 times a day for a clearance of 29 mils per minute, because it's so close to that cutoff. And we know that at best, it's just an estimate of the renal function, and there's probably not a lot of harm in giving extra amoxicillin. Then I might not always call back the doctor and say, like, you have to change this. So keep that in mind. It's a range and an estimate at best, and you can use that and look at the drug risks and benefits. And always weigh that risk of underdosing versus overdosing when you're looking at patient cases. So I will leave it there and open it up to any questions.
I have a question. The first question will be when is the moment where actually pharmacist is performing this intervention? Is it at the bedside, or you do it in the pharmacy department? You do it at the ward, or you have a special room where it's happening?
Yeah, that's a good question. It depends where the pharmacist is working in our hospital. So we have at each of our hospitals a pharmacy dispensary where we're screening all of the orders that come through for the hospital. So oftentimes that pharmacist will see that the patient has reduced creatinine and that the order is too high for the patient, so they'll call the doctor from there. But if it's a pharmacist that works on a patient care floor or in a clinic, then we're often doing it on team rounds or at the bedside.
So does it mean that the pharmacist has an access to some kind of patient medical record, or you do, yeah? And this is something that you monitor on a regular basis. It means that you have like certain timing where you basically have to attend the patient's bed. Then you access the details of the patient, and then you see that his parameters are like not right. And then you decide to make an intervention, right?
Yes, that's right.
And how often do you check on patients as a pharmacist?
It depends on what floor you're working on. I know a lot of our pharmacists that work on the surgery floor, ICU, or internal medicine, every morning when they come in, they'll look at their patient list for the day and look through their blood work before rounds on a daily basis.
Okay. And how many patients daily you could screen regarding the acute kidney injury or GFR or clearance, etc.?
It could be anywhere from 10 patients to 20 or 25, depending on the number of patients on the floor. But I think for patients who have been admitted for longer periods of time, we might not follow them daily and focus more on the new admissions to the floor.
Okay. And you mentioned something that now the doctors, they also can see the GFR and clearance at other parameters. Does it mean that previously only pharmacists could monitor it? Or how does it look like? I mean, how does it work?
Yeah, so previously, our lab system would just report the creatinine, and most physicians didn't know how to calculate creatinine clearance. So I think in those cases, they would either call the pharmacist and ask for advice on how to dose adjust, or we would do it for them or intervene after they wrote the order. But now all of them have access to the EGFR.
Okay, so it means that it happens automatically in a way. So what about the role of pharmacists? I mean, does it mean that you will be excluded or not?
See, I thought when they had access to EGFR, it might have fixed some of the dosing problems, but we still call all the time about dose adjustments for renal function.
Okay. I think what would be very interesting for our pharmacists as well, it would be like, is there any list of drugs which we should be particularly careful to worry about kidneys in general? Where can we find these resources?
I have a list I can send to you that is also from Dan from BC. So yeah, I'll send that along, and it's a list of certain medications to watch out for.
Excellent. This is very, very interesting. I will ask about your systems, because I saw that it's a kind of electronic system where you put the data and then it calculates. Is it something that it's like it's maintained by the hospital, or is it a software? Who invented the software, and you know, where is it from, basically? Who's originally responsible for it?
So the software to calculate creatinine clearance, Global RPH, I think, was developed by a group of pharmacists, and anybody can access it. So if you just go to your web browser and search for it, it should come up. And a lot of the apps like the QXMD and MD Calc were developed by healthcare professionals. So I believe anyone can go into the app store on your phone, and they're free apps. So you just download them and have them readily available.
Excellent. And are there any kind of algorithm used? What I mean, it's is it like somehow programmed to look for a problem? Or, for instance, the patient is admitted to the hospital, the pharmacist is performing the medicine reconciliation. Does it mean that straight away you've been notified that there is a problem, that there may be a problem with acute kidney injury or this kind of things? How does it work?
So, yeah, unfortunately, our system right now doesn't flag that. So you have to manually go in and look at their labs and their creatinine. I know in our dispensary in the hospital that the pharmacists use, we use Cerner and Meditech. And I believe both of those, when you're checking orders and verifying them, down in the corner, you'll see the creatinine clearance. And they calculate that pulling the lab data from our system.
Okay, that looks amazing. And who is entering the data in the system? Is it doctor, pharmacist, or like?
So yeah, in St. John, where I work, we're lucky to have a computerized physician order entry. So the physicians electronically enter the orders, and then the pharmacist would check them in Cerner and verify them. But at our other sites in New Brunswick, they still get some paper orders faxed to the pharmacy, and the pharmacy technician enters the order and the pharmacist checks them.
So can I call you like a renal pharmacist? Is it like somebody who's just going around? And for instance, is it like you're present on all the wards, or that just special wards where you basically perform your regular checks?
So actually, all of our pharmacists on all the floors will look after the renal function assessment. So I work more closely with dialysis and transplant patients in those clinics, but all of our pharmacists are trained to do renal dose adjustment. And I believe under our pharmacist prescribing agreement for the hospitals, we're able to dose adjust the medications ourselves if we feel comfortable.
Excellent. So it means basically that you don't have to get back to the doctor, you just change it.
Yeah, just change it.
Excellent. That makes a lot of sense. You know, like in Poland, we still have to get in touch with the doctor that he will change it. And I think it's very time consuming for them, because first of all, you have to find them where they are. And this is sometimes difficult. Yeah, but anyway, it's still a long way in front of us to be able to be on this level where you are now. So we are just like basically in the kindergarten. So it's happening, but very slowly. So I really enjoy it. It's a very complicated piece of knowledge for me. I absolutely admire your skills, clinical skills and knowledge and experience. It's unbelievable. So thank you very much for having accepting my invitation for this presentation.
If there's anything else I can do, or if you have any questions afterwards and want to chat further, I'm happy to do that as well.
Absolutely. I would love to come back to this topic in the future. This is our first webinar, and we'll see how it's going to work later in the media or YouTube. So I'm sure that there will be plenty of questions, because it's just a new activity that we just started. So I'm sure I will be in touch. And if you just have some time later in a week or two, just to send me this list of these drugs, I could just forward them to the pharmacists who are interested in like renal functions.
Sure. Yes, I will do that. And I can send along a copy of the slides as well if anyone's interested.
Thank you. That would be very, very helpful. Superb. Thank you very much. So thank you very much for this time. I really appreciate that you accepted my invitation, and thank you to our IT for hosting this event with us. Thank you so much. Have a lovely day.
Great. Thank you. You too.
Thank you.